A warm welcome to one and all. This is Dr. Sunil Manuel from the Department of Orthopedics, and today I'll be covering the topic of joint infections. So, before we speak about joint infections, let me clarify that when I speak about joint infections, I'm not speaking about osteomyelitis. As you know, osteomyelitis is infection of the bone and the bone marrow, and we also know that osteomyelitis is more common in the metaphyseal area of the bone, and sure enough, sometimes you can even have diaphyseal osteomyelitis. So, this topic has got nothing to do with osteomyelitis. This topic will be purely about infection in the joints. So these are the two locations where an orthopedic surgeon will be dealing with infections. One would be in the bone, which would be osteomyelitis, and the other would be in the joints, which would be arthritis or infective arthritis. So coming back to slide number 2, so if you take an overview of all the joint infections, we can broadly classify them as septic arthritis, which is caused by pyogenic bacteria. Also, we have fungal arthritis, we have viral arthritis, and we have tubercular arthritis. So, before understanding about joint infections, we have to zoom out and understand what is the spectrum of arthritis. What do we mean by arthritis? Arthritis is an inflammation of the joint. So, an inflammation of the joint could be an infective inflammation or a non-infective inflammation. An example for a non-infective infection would be something like a rheumatoid arthritis or a psoriatic arthritis, or even a condition like a rheumatic fever, which can involve the joint. And the other thing that you should understand is an arthritis, when we have an inflammation in the joint, there are two scenarios, the end result. One is the inflammation can pass away, or the inflammation can heal itself without causing any permanent damage to the joint. On the other hand, you can have an inflammation that can severely affect the joint function. So I'll give you an example. We have a condition called rheumatic fever. So the classic thing that we say about rheumatic fever is it licks the joint and bites the heart. So you have something called arthralgia and arthritis as some of the diagnostic criteria of rheumatic fever. But the most important thing is it is a migrating polyarthritis without any residual damage to the joint, as compared to the devastating consequences that the problem has on the heart. On the other hand, you have also one more similar naming condition called rheumatoid arthritis. In rheumatoid arthritis, you have joint inflammation again, but here you have over a period of time progressive damage to the joint. So what I'm trying to tell you is that an arthritis per se could be an arthritis, either it is infectious arthritis or a non-infectious arthritis, and also an arthritis can cause permanent joint damage, or an arthritis can pass off without causing any damage to the joint. So as a student, you should have a clear understanding of the total spectrum of arthritis. The other thing that I want you to understand is understanding the three sources of pain in a joint. There may be many other sources of pain, but I would put the three main factors as the most important sources of pain in a joint. We'll move on to slide number 3. So here I have put a picture of the synovium. So everything that's marked in green is the synovium, that is the inner lining of the joint. So whenever we have an inflammation in the synovium, so first thing that you should understand is, before that, the joint also has got this hyaline cartilage, and the hyaline cartilage does not have nerve supply. So any inflammation inside a joint cannot cause pain because of lack of nerve supply in the hyaline cartilage. So hyaline cartilage is not the source of pain from the joint. The source of pain from the joint, that is the first source of pain from the joint, is an inflammation of the synovium, and that we would call it a synovitis. So any inflammation in a joint, any arthritis where there is a synovitis, so what you will have is you will have pain in a joint. Why? Because the synovium is richly supplied by nerves. Some of the examples of synovitis causing pain in the joints are transient synovitis of the hip, which is a self-limiting condition in the early stages of rheumatoid arthritis and in the early stages of joint infections. We'll move on to slide number 4. So here I just put this picture of a normal joint, normal articular cartilage, and whenever we see an X-ray, what I've actually shown here in the white arrow is the space in the joint. So we typically call it a joint space, and that joint space is not an empty space. So some students have this misconception that the joint space is filled with synovial fluid. Yes, there is a small layer of synovial fluid, but that's a very microscopic layer as far as the width is concerned. Predominant amount of this width or this gap is actually filled by articular cartilage, which is made up of hyaline cartilage, and this articular cartilage is not radio opaque, and therefore what we do see in a joint is we see a joint space. So one evidence of destruction or thinning of this articular cartilage is loss of the joint space or narrowing of the joint space that we call. So this articular cartilage, as I told you, is asensate. Moving on to slide number 5, when this asensate articular cartilage is now damaged, then what you have under the articular cartilage is the subchondral bone, and this subchondral bone is richly supplied with nerves, and that cause predominant amount of pain in a joint. In fact, the biggest cause of joint pain is loss of articular cartilage and exposure of subchondral bone, and that is exquisitely painful, as you can see in slide number 5 in the picture that I have put. Some of the examples of pain because of loss of articular cartilage are typically that we see in osteoarthritis and in late stages of rheumatoid arthritis and late stages of joint infections. So that covers two reasons for pain in a joint. One would be synovitis, and second would be loss of articular cartilage leading to exposure of the subchondral bone. Coming to the third cause of pain in a joint, it is distension of a joint. So what happens is when a joint gets distended, then the capsule also gets distended. The capsule again has got nerve fibers, the capsule of the joint, and therefore you can appreciate, as in this picture, any condition that causes distension of a joint can cause pain in a joint. Example for this would be effusion, any kind of joint effusion, whether it would be infective effusion or non-infective effusion, you can have joint pains. The other thing is hemarthrosis. So this hemarthrosis could be secondary to a trauma. What is hemarthrosis? Hemarthrosis is nothing but filling up of a joint with blood. So either it could be secondary to a trauma, or it could be spontaneous, like in conditions like hemophilia. So predominantly speaking, these are the three reasons for pain in a joint. One is synovitis, second is loss of articular cartilage leading to exposure of the subchondral bone, and third would be distension of the joint. Predominantly, if you see anybody who presents with a joint pain, you can put it into one of these three criteria. In this list, I have not put trauma as a cause. Trauma causing a fracture, causing an intra-articular fracture, can also cause pain in a joint. But here, by giving these three reasons for pain, I am predominantly meaning non-traumatic conditions. Moving on to slide number 7. So we will start off with septic arthritis. So septic arthritis is the bacterial or pyogenic infection of a joint space. So here we should clearly understand that septic arthritis is non-tubercular. That means tuberculosis, the Mycobacterium tuberculosis, though it's a bacteria, it doesn't come under the definition of septic arthritis. This has to be non-tubercular bacteria. So it's also called pyogenic arthritis. So in this picture that I have put in slide number 7, you can clearly see that there is overlying redness over the knee joint, suggestive of an infection in that area. So if you show me this picture as a spot diagnosis, I'm still not sure whether it is septic arthritis. This could also be a overlying cellulitis. So there are other criteria for making a diagnosis of septic arthritis. One of the criteria is overlying redness or overlying inflammation over a joint. Moving on to slide number 8. So how did this infection now reach the joint? That's the question. The predominant cause of movement of a infection into a joint is through the hematogenous route. So what we need to understand is there is constant bacterial seeding into the bloodstream, but the immune response that we have, that the normal immune response that we have, takes care of most of this bacterial seeding. But sometimes when there is malnutrition or when there is immunocompromise, or sometimes when a normal person themselves are having times when they have immunocompromise, like in a viral infections and things like that, there is spread of this infection into the joint through the bloodstream. So this is the predominant cause of septic arthritis. Other theoretical causes would be due to trauma or due to surgery. There is a direct inoculation of a microorganism into the joint. That would be a secondary cause, and a contiguous spread from adjacent site from an osteomyelitic bone could also be a cause for septic arthritis. But I want you to understand that the predominant cause for septic arthritis is the hematogenous spread. Now, it can occur in all ages, but mainly it is more common in children and elderly adults. Moving on to slide number 9, the most common organism across all age group would be Staph aureus. There is only a small section of people, especially in neonates, that you can suspect some other microorganisms. Moving on to slide number 10. In this slide, I've tried to put in the entire natural history or the pathogenesis of septic arthritis. So in the understanding of any disease, it's very important to understand the natural history. What will happen to this condition if doctors didn't exist or if treatment was not given? Understanding the natural history gives us a clear idea of where our interventions would be most effective. So the first thing that we need to understand is in a septic arthritis caused by pyogenic organism, the cartilage just melts like butter. In a matter of 12 to 48 hours, the entire hyaline cartilage is destroyed. And this is the most devastating thing that can happen to a joint, because initially a joint was made for mobility. And if you lose the hyaline cartilage, the entire mobility in the joint is destroyed. So this is the most important thing that happens in a septic arthritis. And by virtue of loss of hyaline cartilage, what will happen? The subchondral bone will get exposed. So that's by subchondral bone, what I mean is the bone that is intimately in contact, the bone of the metaphysis that is intimately in contact with the cartilage above and the cartilage below. Once the subchondral bone is exposed, then raw bone will come in contact with each other on either side of the joint. So raw bone are now seated touching each other. That's a very painful situation. And if at this stage also, if the patient does not get any medical attention, then what we can imagine is that the pus at some point tracks through the weak links in the weak points in the capsule and starts coming out of the joint. And the end result of a septic arthritis would be, because the subchondral bone is in contact with each other, end result would be the whole thing heals with the fusion of the bone, fusion of the joint. So we call that condition as a bony ankylosis. In this picture, you can clearly see that the joint space is totally lost and there is running continuous bony trabeculae from the bone above to the from the femur moving into the tibia. So now let's move on to slide number 11. So if left untreated or if this condition is unrecognized, as I mentioned, it can result in complete loss of the function of the joint. So therefore, this condition is an orthopedic emergency. Moving on to slide number 12. So how will the patient present to us? Normally, because it's a pyogenic infection and an acute onset pyogenic infection, the child will present with acute onset of high fever and sick looking patient. Along with that, the characteristic feature is a severe pain in the joint, along with inability to bear weight on that limb. The other important thing is there will be absolutely no movements possible at the joint. This is the characteristic feature of septic arthritis of the joint. There is absolutely no movement at the joint. So it's clinically it's very easy to differentiate a patient with cellulitis and septic arthritis, because both of them will present with overlying redness over a joint. But in cellulitis, the patient, though he has got redness over the joint, he will be able to have some movement, maybe not full movement, but at least he will have some movement. But a patient with septic arthritis will not have any movement at the joint. So that is the characteristic feature of a septic arthritis, and that clinches the diagnosis for us for septic arthritis. And there will also be overlying redness and warmth, as I mentioned before. Moving on to slide number 13. So here I have got two pictures. One is obviously of a patient with septic arthritis of the knee, and the other one is a patient who is presenting with a infection or a septic arthritis of the sternoclavicular joint. Moving on to slide number 14. So coming to the blood picture, predominantly the blood picture is going to show us a neutrophilic leukocytosis. Relying on ESR is not going to help us, because ESR starts rising only at 48 hours. It peaks at 3 to 5 days, and it falls back to normal at 3 weeks. So there is no way we can rely on ESR. CRP may be little helpful because it starts rising at 6 hours, peaks at 2 days, and falls at 1 week. Moving on to slide number 15. Microbiologically, what we can do is, whenever as and when we get the pus out of the body, we can send the pus for a gram staining, and we can also send it for blood culture, pus culture sensitivity. But the diagnostic test that I frequently prefer personally would be a blood culture, because this is a systemic infection. Though there is infection localized in the joint, the fact that the patient comes with so much of toxic features definitely shows that there is running organisms in the blood. So before starting the first dose of antibiotics, I would always want to send the patient send a sample of blood for blood culture, which will 99% of the time give me the diagnosis that is, give me the organism and the culture sensitivity at the end of 48 hours. Moving on to slide number 16. What is the role of imaging in the diagnosis? So the first thing that all of us we do in orthopedics would be an X-ray. But let me clarify it here very clearly, that X-ray is absolutely useless in making a diagnosis of an acute septic arthritis. There is no feature that you would see on X-ray except probably for a little bit of a distension of the joint and distension of the soft tissues around the joint, which is a secondary finding. You will not find any features of septic arthritis on an X-ray. So X-ray, mind you, is totally useless. The other diagnostic feature that modality that we commonly use is an ultrasound. So ultrasound definitely tells us that there is some fluid within the joint. Again, it doesn't tell us that it is a septic arthritis or it is pus. It doesn't tell us whether the fluid is blood, synovial fluid, or pus, but it will definitely tell us that there is some fluid within the joint. But the use of ultrasound is to do something called an ultrasound guided joint aspiration. And in superficial joints, we don't prefer to do this, because we don't prefer to put any needle into the joint. Because let's say it's not septic arthritis, we are, by putting a needle into the joint, we are introducing infection into the joint. But sometimes what happens in deep joints, where there is a diagnostic dilemma, we would prefer an aspiration of the joint guided by the ultrasound. Moving on to slide number 17. MRI scan is a very useful technique, especially again when we are dealing with deep joints, and especially when we are dealing with neonates. MRI is very useful. So here in the picture marked with the red arrow, basically what I've tried to show is that there is a increased bone marrow density, and there is increased fluid collection in the joint and around the joint. And this you can compare with the opposite side. Slide number 18 shows how it looks, how septic arthritis looks on nuclear imaging. We don't routinely use this technique in our hospital. Moving on to slide number 19. This is the most important thing that you need to understand as far as the diagnosis. I gave you a complete list of investigations that we can do for making a diagnosis of septic arthritis. But let me tell you, when there is a high index of suspicion, considering that this is an orthopedic emergency, sometimes the patient may also not be able to afford, or the patient may be sick enough for us to be able to be pushing the patient for an MRI scan or for an ultrasound scan. In such a scenario, having taken a written consent from the patient and the family members, we can take up the patient for an emergency drainage of the joint even without any investigations. So this is something that we should know, because the risk of opening the joint far less than the risk of not opening the joint if there is an infection, because as I told you, the infection destroys the joint and the cartilage within a matter of 24 to 48 hours. So let's move on to slide number 20. So there are some principles of treating septic arthritis. So they are called the NAIDS criteria. So basically the point is like this. Let's say you have a breast abscess or you have a gluteal abscess. So what the surgeon does is he does a drainage and he leaves the wound open. So the point that we need to understand here is we cannot do the same technique in a joint. We cannot leave the joint open, because if we leave the joint open, then the cartilage will desiccate and the joint is lost. So basically, as per the criteria of NAID, what we need to do is we need to drain the joint and we need to close the joint over a drain. So that is important. So we need to put a drain inside, a suction drain, and we need to completely close the joint. We need to close the capsule and we need to also close the skin. So this is very counterintuitive as compared to infections in many other parts of the body. The second important thing is, initially we need to give systemic antibiotics and then we need to give culture specific antibiotics. And the third and most important thing about managing a septic arthritis is that the joint should be splintered for two reasons. One, the joint, basically what happens is, when there is a septic arthritis or when there is an infection, the muscle forces or the muscles around the joint tend to take the joint into spasm, into you can say an unfunctional position or an unhealthy position, and the patient can have now a fusion or a loss of joint function in an unhealthy position. So we don't want that. We want the joint to be rested, yes, but we want the joint to be in some kind of a functional position. So the best thing that we can do is we do immobilize the joint in defined functional positions of the joint. Moving on to slide number 21. As I told you, the first thing is about splinting the joint, then giving broad spectrum antibiotics and doing a surgical drainage of the pus. Now with this surgical drainage, there are two techniques again. We can either do an open surgical drainage or we can do an arthroscopic surgical drainage. So for superficial joints are easily accessible. We do an arthroscopic surgical drainage. Commonly we do this kind of drainage in the knee joint and in the shoulder joint. In most other joints, we would in the deep joints we would want to do an open surgical drainage. So slide number 22 is showing a picture of the hip joint where we are draining through an open surgical drainage, and slide number 23 shows a picture of an arthroscopic surgical drainage where the knee joint is being drained by the surgeons in the using an arthroscope. And the same arthroscope, after draining out the joint, draining out the pus, can be used to give a nice joint wash inside. So all the entire joint can be washed inside, and through the same portal through which the arthroscope was placed, a drain can be put inside and the joint can be closed. Now there is this question of can we just put a needle, aspirate the joint and treat septic arthritis? So in my opinion, needle aspiration of the joint is not a treatment for septic arthritis, because our aim should be to take out the infection or the completely take out the infection. Otherwise the joint is anyway going to get destroyed. But there are going to be sometimes very high risk individuals, like very elderly people in ICU, and people who are probably in sepsis and totally unfit for surgery. Sometimes neonates with neonatal sepsis. In such conditions, the pediatricians themselves will tell us, no, don't take this child for to the OT for anesthesia, because the child may not make it. In such situations, we do something called aspiration of the joint to reduce the infective load on the body, but I would definitely not recommend it as a treatment for septic arthritis. moving on to slide number 25. Coming to the complications. So now that you've understood that septic arthritis can cause so much of devastation in the joint, so obviously we should understand that even well treated septic arthritis can end up in bony ankylosis, to a fair degree of bony ankylosis. However, other complications would be destruction of the epiphysis. So many of the joints have got their epiphysis which are intra-articular. So the epiphyseal plate, if it is damaged because of infection, can lead to shortening of the limb or lengthening of the limb sometimes. So I wouldn't want to call it shortening or lengthening. I would use a word called limb length discrepancy. So shortening of the limb is seen in 95% of the cases with epiphyseal damage, but with physeal damage. But sometimes in 5% of cases you can have paradoxical lengthening of the limb because of increased vascularity of the growth plate. We can also sometimes have angular deformity like genu varum, genu valgum, all secondary to septic arthritis. The other very dangerous consequence is separation of the epiphysis. So the entire epiphysis separates from the metaphysis in a case of septic arthritis. This can occur because the growth plate is cartilaginous, and therefore the growth plate is a weak point. So the infection, once it invades the growth plate, can cause an epiphyseal separation. Very often septic arthritis, as I told you, not just destroys the joint but also destroys all the supporting structures within the joint. So it is not that just the hyaline cartilage is going to be damaged. In the knee joint, all the stabilizers like ACL, PCL, everything is going to get damaged, and therefore you will have once the patient recovers also, you will have some amount of subluxation or instability in the joint. The most devastating complication of septic arthritis, or you can say in a way the end result of septic arthritis, would be a bony fusion or a bony ankylosis. So in slide number 26, I have put a picture of a patient with I have put two pictures, one with bony ankylosis of the knee and the other is bony ankylosis of the hip. So these are all as a end result of septic arthritis. Okay, so moving on to slide number 27. So there is this unique entity called Thom-Smith's arthritis. So basically what happens, this is the end result. Thom-Smith's arthritis by definition is the end result of a neonatal septic arthritis of the hip joint. So in neonates, basically we have this condition called neonatal sepsis. So as part of the neonatal sepsis, I told you that septic arthritis is predominantly coming into the joint due to through the bloodstream. So what do you expect if a neonate has got sepsis or septicemia in the bloodstream? Obviously the joints are also going to be seeded. So this is a very common condition in children with neonatal sepsis. So very often we get references from the PICU telling us that there is a baby with whose hip is not moving or knee is not moving, and we go and evaluate the baby. So basically what happens is at the time of birth, the hip joint is the head and the neck of the hip is predominantly cartilaginous. So I told you septic arthritis destroys the cartilaginous hyaline cartilage. So here what is happening is the entire head as well as the neck is cartilaginous. So what do you expect? Completely the head and neck would be damaged if not attended to very aggressively, either with antibiotics and also by surgical drainage. So this is one very important place where we also in collaborate work with the pediatricians and try to work out a plan so that the baby can be immediately taken up for surgery, and we will be happy to drain the joint and to prevent this condition called Thom-Smith's arthritis. So here in this picture in slide number 27, what you're seeing is you're seeing a child of probably I think above 30 years, so above 4 years, and from I'm able to judge that from the opposite side hip. So on the right side what you are seeing is there is no head and neck in the joint, so it's completely damaged. So the sequelae of this as the person grows up would be as what you see in slide number 28. So this would be this was not the same person, it should be somebody else, but you can also see at this stage the entire hemipelvis is ill developed. That's because that limb is not bearing any weight, that hip joint is not functioning. Because of that, the entire half of the pelvis is ill developed as compared to the normal left side, and also you will see that the femur is also ill developed. So these are the sequelae of a neonatal septic arthritis. So in the neonates also, as the pediatricians are treating these babies in the NICU, they will be constantly keeping a watch on the limb movement, whether the limb is actively moving. Whenever they say even a paucity of limb movements, they will immediately inform us so that we will be able to evaluate. The frontline investigation that we do in neonates would be a ultrasound of the hip, and if the ultrasound of the hip is showing any fluid, it doesn't matter, it doesn't need to be pus. We will just convince the family, and we will also have to convince the pediatricians that we want to take up this baby for a drainage. Considering the setting of neonatal sepsis, 99% of the time we end up getting the pus with the same organism in the joint. Moving on to slide number 29. So fungal arthritis is not very common. Whenever we see that, we see it only in immunocompromised individuals like diabetics and HIV positive patients, and most likely the causative organisms are Candida. So we would treat fungal arthritis with the same antifungals, mostly or initially injectable for 2 weeks, and later on we go on to oral. Alright, with that we end the session on septic arthritis as well as fungal arthritis. In the next session, I'll record one more lecture on tubercular arthritis. Until then, keep learning. Thank you.